This video covers some basic facts about autologous breast reconstruction and then gets into some discussion of advanced procedures for challenging candidates who may have been told they are not eligible to use their own tissue. There are many topics covered here. If anything is unclear, please refer to my website, centerforbreastreconstruction.com. Autologous breast reconstruction is the gold standard for mastectomy patients. This means that when breasts are removed, they are replaced with the patient's own living, natural body tissue. These surgical procedures remove or harvest living skin and fat from an area on the patient's own body. The living skin and fat is harvested from an area that may have extra, so that taking away from that area will not cause a problem. This area from which the skin and fat is taken is known as the donor site. Common donor sites are the lower abdomen, the thighs, and the buttocks. Living tissue that is harvested for use in reconstruction is called a flap. Flaps are harvested along with key blood vessels that supply it, which are plugged into blood vessels in the chest when the flap is transferred. Once the blood vessels are plugged in, the flap lives in the chest and resembles a new, soft, and natural breast. It is important to know that unlike similar procedures from the past, the best techniques of today do not damage or sacrifice muscle in order to harvest living tissue for breast reconstruction. Many breast cancer patients seeking reconstruction are told that they are not candidates for autologous tissue reconstruction. These women often end up with implant reconstruction or no reconstruction at all. The reason that many women are not offered autologous breast reconstruction is usually that the plastic surgeon feels that they are too thin and therefore do not have enough tissue to donate to their chest for breast reconstruction. Other reasons may include prior surgery like liposuction or tummy tuck, or multiple medical problems, particularly bleeding issues. Patients who would like to consider autologous tissue reconstruction but have been told that it is not an option should definitely seek a second opinion from a plastic surgeon who specializes in autologous tissue reconstruction, because there are many ways to offer autologous tissue reconstruction in thin and otherwise challenging patients. The most common donor area for autologous reconstruction is the lower abdomen. This is the skin and fat below the belly button and above the pubic hairline that you can pinch when seated. It is the same skin and fat that would be removed in a tummy tuck procedure. If a patient has had operations in the past that render this donor site unusable, for example, a tummy tuck or extensive liposuction, this donor site may not be available to use in breast reconstruction. In this case, the patient may be told that she is not a candidate for autologous reconstruction. Patients should know that any area of the body where there is extra skin and fat can be used as a donor site. This includes the thighs, the buttocks, the lumbar fat area, and the back of the chest underneath the arms. If the abdomen isn't an optimal donor site and the patient would like to consider autologous tissue reconstruction, the patient should find a surgeon who is able to offer one of the other, less common operations. Other reasons that patients are turned down for autologous reconstruction is that they are quote unquote too thin This means that the surgeon is not confident that they can harvest enough tissue to make 1 or 2 breasts. The important thing to remember in these patients is that although thin women may not have much tissue to donate, thin women don't need much tissue to make breasts that are appropriately sized for their bodies. For these women, it is important to offer autologous breast reconstruction with the understanding that the reconstructed breasts may be relatively small. This turns out to be perfectly fine for many thin women. However, if more tissue is indeed required, it is always possible to optimize the amount of tissue and thereby increase the volume harvested for breast reconstruction. In order to understand this, it is important to know that flap tissue must be transferred with the key blood vessels that supply it. These key blood vessels are tiny, and they have the ability to perfuse a limited area of skin and fat. In the standard flap operation, 1 blood vessel is selected, and the volume of tissue that is harvested is limited to the extent to which this 1 blood vessel supplies the tissue into which it flows. Like a sprinkler system, the blood vessel going into the harvested tissue will perfuse a volume related to its size, position within the tissue, and the pressure within the vessel. At some point, its ability to perfuse will drop off, and the tissue beyond that point will not receive enough blood and thereby will not be oxygenated. It is at that point that the flap will be trimmed so that only the well-perfused tissue will be used for the reconstruction. When the abdomen is used as the donor site for breast reconstruction, these operations are called DIEP flaps. That stands for Deep Inferior Epigastric Artery Perforator flaps. This name describes the actual blood vessel that supplies the tissue by perforating through the abdominal wall musculature. Since the key blood vessels in the abdominal flaps usually emerge around the midline, this means that hip fat, which is farther away from the point at which the blood vessel enters the flap, is usually discarded or not harvested at all. In these cases, we will employ an advanced microsurgical technique in which another blood vessel is taken along with this extra tissue. The extra blood vessel supplies the tissue that is too far away from the main DIEP blood vessel, and this allows us to harvest more volume. The second blood vessel, also called a vascular pedicle, is then plugged into a branch on the main vascular pedicle. In this way, tissue that would not have been usable is now added as valuable, healthy volume to reconstruct a larger breast. This operation, which I described in 2018, is called the Stacked Hemiabdominal Extended Perforator Flap, or SHAEP shape flap. And there is a video on my YouTube channel which explains this in further detail. Another way to address low volume in this patient population is to include more flaps from other sites. If a patient doesn't have enough to make suitable breasts from one donor site, then a combination of flaps may be indicated. Any two donor sites can be combined to obtain more volume and create larger reconstructed breasts. Once the flap reconstruction is done, the patient will typically have another smaller procedure about 3 months later in order to improve the outcome with minor touch-up procedures. This may include fat grafting to the reconstructed breast in order to improve appearance and symmetry. And this is another way to add volume to a reconstructed breast in a thin woman. With advanced techniques and creative ideas, there are many ways to offer breast reconstruction to thin women and those who have had prior surgery. Anyone who is a candidate for breast reconstruction is a candidate for autologous reconstruction. I hope this video was helpful in understanding some of the more nuanced and advanced topics related to breast reconstruction. There were several difficult topics to understand covered within this video. If anything is still unclear, please refer to my website, centerforbreastreconstruction.com, or take a look at some of my other videos covering some of the more basic topics.